Good morning, everybody. This topic is not easy, as we see, because when we talk with our friends, gynecologists, urologists, and talk about pelvic floor prolapse and something like this, they say, oh yeah, surgery. But what examination you do before surgery? No, we don't need examination. We know there's a prolapse. We take away the prolapse. We take up the bladder. We don't need nothing. But we have learned that we need a lot of things. We need manometry, defecography, MRI, ultrasound, and so on. So where is the truth? We need this examination or not. And this is controversial, of course. But we have to intend what we mean for obstructed defecation, because obstructed defecation is not a disease, it's a symptom of many different etiologies. And for example, if we have an obstructed defecation with a functional origin, nobody needs surgery. Otherwise, if we found some anatomical alteration, maybe we can consider that as the main cause of the obstructed defecation. So if we treat them, the obstructed defecation can improve. But this is, again, not always true, because we know the iceberg, the theory of the iceberg, in which maybe we can see rectocele, enterocele, but there are many, many other conditions that we usually don't consider. But everybody of us has in his office some patient that he say, oh no, she has a rectocele, she has an enterocele, she has every kind of cele you want, but she's crazy. I will never touch her. And this is true. So what kind of examination can tell us if she's crazy or if she has an anatomical alteration? And we can say something more. For example, if we found a rectocele, well, we know that up to 80% of female without obstructed defecation have rectocele. Okay. And we also have that the prevalence of obstructed defecation in women with rectocele varies between 23 and 60%. That doesn't mean nothing. But patients come in our office and say, doctor, I'm here to be operated. Oh, for what? I have a rectocele. My gynecologist tell me, so I have to be operated. But you have symptoms. No, but I have a rectocele. So what means to have a rectocele? What means to find a rectocele? Maybe don't mean nothing. And if we consider, for example, internal prolapse, intussusception, what does it mean? Maybe nothing again, because if we look at the literature, the main symptom associated to internal prolapse, is fecal incontinence. And if we take a lot of healthy volunteers, 1 every 3 may have an internal prolapse. So we have the egg and the chicken, no? The rectocele, the intussusception are the cause or are consequences of a functional dysfunction. And we don't know, but for example, if we take obstructed defecation woman with or without rectocele, they have no difference in symptom, in problem, in other abnormalities. So the rectocele may be a cause of obstructed defecation. We want to demonstrate the rectocele with some examination. We don't know. But we can find an enterocele. Wow, enterocele is perfect. You have an enterocele, you are very bad. You need surgery. But this is not always true, because we can have, for example, a functional enterocele that gives no symptom. And this is the majority of the enterocele that we found. An obstructive enterocele, but that push the rectal ampulla just at the end of the defecation. So he has no obstructive power. And only a minority of enterocele have an obstructive condition. And if we see patient with enterocele or with symptom, just this group have a real significance of the problem. So to find an enterocele during imaging is not so important. The important is the symptom. And always talking with our friend, not so friend maybe, but our friend gynecologist and urologist, we have learned that if we ask to our patient if they also have some urogynecological problem, 1 every 3, and maybe more, have this. And if they ask to their patient if they have, for example, constipation, of course they have. But the most important thing to understand if imaging can tell us something useful, that this is the real question. The real question is not we want to do some imaging, we need some imaging. The real question is what we ask to the imaging. There's something that the imaging can tell us that may change our treatment. And this is what we learn, for example, with star surgery. We learn that patients with, for example, pubilorectalis dyssynergia have a poor outcome. Of course, they don't need surgery. And patients with large rectocele, with low sphincteric pressure, very increased pelvic floor descent, maybe not benefit from star surgery. So this is what we want to know from imaging or functional examination. These parameters, because I know that if my patient has something of this, it may fail a perineal approach. But we have an optimal examination. No, of course we don't have, because an optimal examination must fulfill all these criteria, and no examination have this power. We know, for example, that defecography is the best for the study of the posterior compartment and the defecation process. But he has not the same power of MRI, for example, to give a complete 3D imaging of the pelvic floor. So, for example, if we need to know something about uterus, about bladder, 1 every 3 patients, maybe defecography is not enough. But MRI don't have an evacuation phase. So how can I study at the best that moment? We cannot. And transperineal ultrasound may be an optimal option. if you are able to do it. But it's not always in that way. Of course, if we have a pelvic perineologist, we don't need the MRI, we don't need the defecography, because in the visit, he or she take the ultrasound probe, and the ultrasound is part of the perineal evaluation, just like an anoscopy or a colposcopy. So all this discussion doesn't exist. In fact, if we compare ultrasound with the defecography, ultrasound gives every single information with a good concordance with the defecography, and maybe give us also more information about all the pelvic floor organs. And if we go to look to the thing that we want to know, that are this, we see that there's not a single examination, that every examination, but not a single examination, can give us some information, but not all the information about that. But now we have also high-resolution manometry. In the same period, comes out 2 papers that conclude. One, the agreement between MRI and high-resolution manometry is high. Wow. But the other, were unable to find a correlation between MRI and manometry. So where's the truth? We need manometry? We don't need manometry? We still don't know. We know, for example, that manometry have a high grade of evidence in telling us if the patient have a dyssynergia, if the patient have a low sphincteric pressure. And maybe if we want to know this, we have to ask for a manometry. If we just know, if we don't know, we don't need manometry. Also because, as just said, there's no correlation with manometric results and symptoms. We can have patients with low pressure or with dyssynergia without any symptom. And otherwise, we can have patients with obstructed defecation with no manometrical alteration. So we need or we don't know. But for sure, for example, this is the recently published algorithm that they use here in Pisa, but that I agree. If you want to do this, if you want to decide for every single of this way, I think that you need to do something to better understand the situation. But it's not always the same. The message is not that you need manometry defecography in every patient, but you need to answer to some question that you may have during the evaluation. Because obstructed defecation is a functional disease, just sometimes associated with anatomical alteration that we don't know if are the cause or are consequences. And the most important message is this one. So be careful when you ask for an examination, because the examination gives you an answer, and maybe is not the answer that you want to hear. Thank you very much.